Okay, so it's 12 o'clock, and I know we have to maintain schedule because people are getting hungry. Is Dr. Van Besien here? So you've heard a little bit. Thank you, Koen, and you gave in your memory stick. Okay, thank you. So you heard about a lot about transplantation this morning from Dr. Hasselbach and also from Dr. Hoffman. And so Dr. Koen van Besien, who is in charge of our transplant unit here at Weill Cornell, is going to give us an update on transplantation in MPNs. Thank you, Koen.
Thank you, Dick. So it's hard to follow the previous speaker, and I kind of like that quote about us trying to correct things even if they don't need correction. But as transplanters, we are called when things are problematic. And I don't know whether Dr. Silver gave me this task or whether I came up with the title, but I thought I'd give an overview of what has changed in transplant, a little bit in general over the last 15 years perhaps. And I will warn you ahead of time, nothing spectacular has changed. Whatever we have done has been very incremental. There's a lot of minor changes, I think important changes. And I'm starting with this. This is from when Dr. Hoffman and I were together in Chicago. We published this. These were 4 patients with myelofibrosis, 3 of whom there are pictures here. And this was their marrow before the transplant, and they had a lot of fibrosis. You see the black lines here, the black lines there, the swirls of fibrosis there. Then we did the transplant, and after the transplant, practically everything normalized. From this, it went to a marrow that was cellular, that had much less fibrosis, a marrow that was cellular, that had some fibrosis left, but practically resolved, and in the 3rd patient, complete resolution of fibrosis. So transplant can cure patients with myelofibrosis. There's no doubt about it. So why don't we do it for everybody? Perhaps because some people don't need it, but more importantly, because it's a difficult and dangerous procedure. But I will try to convince you that things have improved, at least in the field, in a variety of ways. And I will talk about these 6 different aspects. We can find now more donors for everybody. We've improved in the way we give conditioning regimens. Conditioning regimens is the chemotherapy or radiation we give before the transplant. There's a lot of effort that has gone into that. We deal better with graft versus host disease than we did, and I'll talk a little bit about that. Importantly, we are much ahead in preventing infections. Patients who undergo transplants, at least in the first year, are very immune suppressed and are very prone to infections, and I think we do a whole lot better than we did in the past. We know how to select our patients better based on their overall health, also based on their disease status. One is the approximate best time to offer a transplant. And when I have discussed all this, what has this all led to? So let's start with these donors. So the paradigm of transplant, as originally proposed by the Seattle group, or now 40, 50 years ago, that one needs an HLA identical sibling, a sibling who has the same HLA type. And the HLA, it's a set of antigens located on chromosome 6, and they are important in immune reactions, and they are inherited from father and mother. Therefore, we share half of our HLA with father, half with mother. With brothers and sisters, about 1 out of 4 shares the same HLA type, inherits the same chromosome 6, the brown one in this case, from father, and the same one from mother. Those were the donors that could be transplanted. That was, for the longest time, the limitation. How many of us have such donors? Relatively few. Depends on number of brothers and sisters. Depends also on their health. As we age, our brothers and sisters also age, and so forth. So it's a problem. How do we get around this? We find unrelated donors, and I cannot find an update to this slide, but as you see, in 2009, there were 8 million people in the world who were willing to donate cells for patients anywhere. And yesterday I did a bone marrow harvest on a 24-year-old woman who donates for somebody she's never seen. And I find that actually quite amazing and a cure for all cynicism because this young woman doesn't get anything for that. And she goes under general anesthesia and will hurt for a week. But there's millions of people who are willing to donate. And by having millions of people who are willing to donate, we can offer matching transplants for a lot of patients. That's not news anymore. So, but what is news is that this is an example from our own unit. Of all the transplants we did in, I believe this is 2016 or so, only about a quarter were with these matched siblings. Many more were with these matched unrelated donors. And a lot more were for patients who didn't even have these matched unrelated donors. These HLA types go with ethnicity, go with origin, and there's plenty of people, particularly of minority descent, who do not have such donors. And as you see, that doesn't stop us any longer of doing transplants. We now can do transplants with mismatched cord blood grafts. We can do transplants with partially matched siblings or with partially matched parents or children. And how are the results? I will just show you what the advance is. I think this is a useful way of illustrating this. This is from Europe, but you could show the same here in the United States. These are outcomes of transplants between 2001 and 2005. Transplants performed 5 years later, and then transplants between 2011 and 2016. The top curve are the matched siblings. And you see that over time, the outcomes have improved a bit. The curve shifts a little bit. Survival of these transplants has improved, so that's an advance. These are the perfectly matched unrelated donors. They're slightly inferior, but really not much. They're practically the same. So the outcomes are quite good and have been good for quite a while. This improved around this time. But these are these mismatched transplants. These mismatched transplants back in 2001 were really considerably worse. And they are improving, and they are improving. They are not exactly as good yet as the matched siblings, but progress is made every year due to a variety of technical interventions. There's new GVH prophylaxis, new ways of identifying these donors. Too much to go into the technology, but as you see, this is no longer a major detriment. So when a patient comes to me and says, I need a transplant, you don't have an unrelated donor, I will tell him this is a little bit more difficult, but if you need a transplant, it can be done. And it can be done many times with good results. So that's one aspect. Conditioning regimens, very complicated. A long time ago, we talked about myeloablation versus non-myeloablative, reduced intensity chemotherapies. We have spent as a community many, many years trying to develop better tolerated and equally effective regimens as the old regimens that were developed back in the 1970s. And there's at least 5 or 6 regimens around that are commonly used, and they are clearly better. And I'll show you just one example. We have also made major advances in avoiding toxicities of transplant, the immediate toxicities. When I started together with Ron years ago in Indiana. Patients were sick as hell. I mean, there's no other way around it. It was really suffering. These days, my patients walk around the ward. My patients, they're not perfectly healthy. They don't have much appetite, but many people are working on their laptop computer, watching TV, working out on their exercise bicycle, get through this without too many problems. I'll show you one example of a very recent study of a new drug, not available here in the States yet, but it's studied in Europe and probably soon to be available here in the States. A drug called treosulfan that was compared with the commonly used drug busulfan. You've heard already from previous speaker about busulfan, but we use it traditionally in high doses. This newer version of this alkylating agent, when compared in a randomized study, half of the patients get the busulfan, half of the patients get the treosulfan, clearly superior. clearly superior outcomes, and mostly because of less toxicity, less side effects. So this is, don't want to emphasize this too much, this particular drug, this is just an example of one of the many ways in which advances are being made. GVHD, don't know how many of you are familiar with it, but it's quite, at its most severe, it is a scary, concerning complication. When it gets really severe, it can affect quality of life. It can be very prolonged. It can make the outcome of transplant regrettable in the sense that sometimes we cure patients and we are left with another disease that is worse than the one that they had before. And it is something that we try to minimize, and that has really led a lot of patients to not choose transplant, a lot of referring physicians not to refer patients for transplant. There too, we are doing better. We are doing much better. And I'll show you again a couple of examples. This is a recent study of a new prophylaxis regimen. There were 4 regimens were compared, and the details don't matter, but you see 4 curves here. And one, this is the incidence of chronic graft versus host disease in this particular study at 12 months. And what you see with 3 of the regimens, it was about 30%. With 1 regimen, it was clearly inferior. So, sorry, I pushed the wrong button here. Let me go back. And so advances there, gradual advances, nothing spectacular. This is from our own cord blood transplants compared with adult donors that were mismatched, and with cord blood transplants, then in the fashion in which we have done our transplants, we have an extremely low incidence of chronic graft versus host disease. This procedure has other issues, but that's one of the advantages of this procedure. So again, quite remarkable advances. It's kind of interesting to know that also treatment of graft versus host disease, once patients have developed graft versus host disease, then we need to treat it. And there too, treatment has much improved. And once one of the most remarkable agents of the past couple of years is actually ruxolitinib, which you all are familiar with, but which turns out to have a major impact in the treatment of graft versus host disease. Another aspect, infections. Our patients, as I told you, are extremely immune suppressed after the allotransplant, at least in the first 6 months, some of them longer. We have to be concerned over fungal infections, viral infections, reactivation of infections, sometimes community acquired, sometimes reactivation of viruses we all carry around. There too, our infectious disease colleagues and the scientists and the drug companies have all contributed to major improvements. We have better methods for detecting infections, for diagnosing them, and better drugs for treating them. This is just the last new kid on the block here that has dramatically improved, actually, the ease in which we do transplants. This drug, letermovir, is for a very common infection called CMV that we reactivate and that we struggle with, because until recently we had only toxic drugs that caused myelosuppression, low blood counts, or renal failure. Letermovir turns out to be quite effective and have hardly any side effects. And, sorry, going the wrong way. This is from a paper in the New England from a year or 2 ago when letermovir was compared with placebo in transplant patients. The reactivation risks of CMV went way down. And this drug has pretty much avoided completely CMV for our patients. Unfortunately, like many of these things, it is expensive. Some insurance companies don't cover it, and for some patients we struggle to get it. And that can lead to problems. Couple of other points. How do we select the patients? And I'm going to talk for a couple minutes about patient status and then about the disease status. So patient status meaning which patients, who is an appropriate patient, who is too frail, who is too old, What does it all mean? These are our own patients at Cornell. I told you already, a lot of partially matched transplants, a lot of unrelated donor transplants, but this is the age distribution of our patients. And already a couple of years ago, so relatively few patients are under the age of 50. The large majority of our patients are late 50s, early 60s, up to mid 70s. That would not have been true 15 years ago. 15 years ago, and these are now national data, this is the percentage of patients that were under 60 versus over 60 in the time period 92, 98 in the United States. There were hardly any patients transplanted over the age of 60, and nationwide this goes up, and in New York it probably goes up more. Why does it go up more in New York? I think New Yorkers are simply healthier. They're also relatively wealthier than the average population, and but I think this is something that will continue to happen. But we cannot transplant every older patient. There are some patients who are really not in good enough health, but how do you define this? And it's been a challenge. We talk about frailty, but what is frailty? And some of my colleagues say you recognize it when you see it, and to a certain degree you do, but I don't, and I struggle with this all the time. I see patients in the clinic, and they need a transplant. They have a disease that requires a transplant. And then am I going to turn them down because they have had serious health problems? If this is their only option, it's quite complicated to do that, and with great reluctance do we do that. One of my colleagues, Andy Arts, who's now at City of Hope, and Laurie Muffley, who was our fellow is now at Stanford, studied some predictors of outcome, and they looked at the comorbidities, meaning how many prior, does one have diabetes, does one have heart disease, does one have issues with the lungs, kidney problems. That was by itself not a great predictor. But in addition, the combination of comorbidities and how active people were, what was called the instrumental activities of daily life. Are people running their own business, doing their own finances, maintaining their own house, doing their own cooking? Those turned out to be very, very powerful predictors. And we could come up with this kind of categorization. And if patients had a lot of comorbidities and were very inactive, then really they didn't do well. If they were quite active and had relatively limited comorbidities, they did a lot better. This is far from perfect. This is still a challenge to recognize these patients, but we are starting to get there. And a lot of people are interested in studying this better. Now, lastly, well, not lastly, this also is important, I think, education of the patients, and this comes from Xenia, who has really put this together on the web, based on disease categories, blanking on the name now, the prognostic index. Patients can decide on how advanced their disease is and how likely it is that they will need a transplant. Are they high risk, moderate risk, low risk? I think patient education in that sense is also quite important. But we are going a step further, and this is again for myelofibrosis patients, which is these days the most important indication for allotransplant. Our colleagues in Germany came up with a predictor of how well patients did after transplant. So they looked at a large number of patients, and they came up with 7 predictors. Age greater than 57, performance score, meaning how active you are, how healthy you really behave, whether you had a JAK2 or not a JAK2, non-CALR or MPL, so meaning JAK2 basically, having an ASXL1 mutation that may have been talked about, type of donor, matched versus mismatched, high white count, low platelet count, all of them get 1 point, except a mismatched donor in their experience got 2 points. I'm not sure that's still relevant because these data are already old and from the time that we couldn't do very well mismatched transplants. and the JAK2 got also 2 points. But what are the outcomes? If you add these numbers up for individual patients, if you're in a low category, you have a reasonable donor, and you have a JAK2 mutation only, you have quite an excellent outcome here. Even if you have, even if you're older than 60 and you have reasonable disease status and a reasonable donor, you still have over 80% outcome. As the adverse features accumulate, the outcomes go down, but they never go, except for really patients with very advanced disease, they don't go below 50%. So we're getting better and better. So a number of, as I told you, nothing spectacular, all incremental. But what does it mean? What does it mean for the individual patient? And these are data from the National Marrow Donor Program. National Marrow Donor Program is the organization that across the US delivers us, organizes the transport and identification of donors. Like the young woman I did a harvest for yesterday, I'm not even sure where her marrow is going to. I'm not told, but they tell us they will take care of it and they deliver it to the center that needs the graft. So they facilitate all the mismatched transplants across the country, and they also keep us honest, in the sense that they gather the outcomes of all transplants done across the country. They gather them on a yearly basis, and there's approximately, from year to year, more transplants are done. 2008, there were 6,000 allotransplants. This is not just myelofibrosis, of course. This is all hematologic malignancies. Now it's up to 8,000. So the numbers go up. And then they do a multivariate analysis. Clearly, certain things predict for outcome. Do you have a matched sibling, a mismatched transplant? Are you older? Are you younger? Do you have acute leukemia, myelofibrosis? And at the end, one of the predictors ends up being the year in which the transplant was done. So if you had an outcome of 1 in 2008, in 2009, it went up to 1.08 and so forth. For the same patient, the hazard ratio is now up to 1.77. These are not data from Cornell. These are not data from any center in New York. These are data from transplants performed across the US. What does this mean in practice? If a patient had come to me in 2008, and I don't have a crystal ball, I have a guess of how he or she is going to do, and I'm going to tell that gentleman, listen, you have this disease, you have a little bit kidney problems, you have this donor and that donor. I estimate your outcome is about 50%. Not great. That exact same patient would come to me in 2016. That's the last year that I have data on. I could tell him your outcome at 1 year survival. This is not cures. This is a very simple outcome of making it to 1 year is dramatically improved. So we have not made any massive, we have not invented a new tyrosine kinase inhibitor, no CAR T cell, but I think the work of many, many people in this field has steadily improved the results. And I think this is quite encouraging. And I want to go back to this, to this slide. Really, these results are almost too good to be true, but they are probably correct. They are, if patients have average risk myelofibrosis, the outcomes these days are quite excellent. And again, keep in mind, this is 100 months follow-up, so some of these patients were already transplanted 10 years ago. Since then, the outcomes have improved further. Just the last slide with this, these are our own results, and it's just reflective of over the last couple of years. Every year, our outcomes become a little bit better. So in conclusion, I hope I have convinced you that we have made improvements. It remains a difficult procedure. I don't think anybody, Dr. Spivak just told us, nobody needs a transplant who doesn't need a transplant. We should only do it for patients where we are convinced that it's the best solution, but it's much more an optimistic field than it was. Thank you.
Koen, that was very exciting information to share with the group. We all are patients, and we all have insurance issues. How often, and I've been asked this by my patients, how often does a transplant not been able to be accomplished because of insurance issues in the United States? I guess, and we'll ask Dr. Hasselbach, because I guess the situation in Europe is entirely different.
Very good question. We bankrupt our patients with our transplants. We fight very hard to get approval. Not happening is unusual, but we talked, for example, about this drug letermovir. I have now a patient in the hospital who couldn't get letermovir. So it's a pill. It's dramatically changed what our patients made our transplants a lot better, but this particular patient couldn't get it because of insurance purposes. And this particular patient is admitted to the hospital right now with a very severe CMV disease. And it's absurd because the drug would have cost a couple $1,000 a month, and now she's, from a purely financial standpoint, she's going to cost $500,000 probably to the insurance company. And so we deal with that kind of thing on a daily basis, getting drug approvals, because this is a very complicated issue, and there's always unexpected costs, getting patients back and forth to the hospital. I could show you a slide. I took it out, but there's a slide also from National Marrow Donor Program. I told you, year of transplant is a predictor of outcome. Year of transplant, I just showed you last time, but another extremely important predictor of outcome is wealth. And I could show you, I took the slide out of here, but the outcome of a patient less than 10th percentile family income versus 90th percentile family income, the outcomes are 60% better. And it's more than just drugs, it's also social support, sure. It's everything.
But that's not unique for transplantation. I mean, that's for cancer care in general. Yeah. So, Dr. Hasselbach, I think the group would be interested in what the status is in Europe. Can you speak of Europe in general, or Denmark only? Or
two points.
Can everyone hear Dr. Hasselbach? No. Is the mic not on?
Can you hear me?
Hans, why don't you come up here, because it's a very, very interesting topic.
But two important informations. I am not a transplanter. And that is a very important. Second, in Denmark, we have not this issue of insurance because we take care of everybody, irrespective of money. So we have not that problem to face in Denmark. Everybody who is considered a transplant candidate will have the possibility to be transplanted, irrespective of what he or she earns or finances.
And how about other countries in Europe?
I don't know.
I would think, if I may add, I'm from Belgium. I think it's the same everywhere in Europe.
Yeah, I think so. So it is in Europe. I think that I could speak. My tongue speaks from most countries. Yeah.
Now, since you bring up that topic, there's an entire group of patients who we never see, and they are the undocumented aliens. And there's a lot of, we all know them. They clean our hotel rooms and they work in our, and these people also get sick, and they often only have emergency room care. And we don't even see them. In Chicago, I sometimes saw them. Here, they don't even come close to this hospital. So I think there's 10% of the population, depending on what you think about that, but it's a fact.
Thank you. A very important issue. Well, we could discuss this forever, but Mr. Booley is here to plan our administrative activities.